Okay, so as we all know, all herniations which are displaced away from the index end plates are called as migrated herniations, and this can be seen in up to 72% of the cases, and up to 40% are high migrated. This can be sequestrated as well and non-sequestrated. So the grades already has been discussed by the previous speaker. They had been graded in 6 grades. The thing is, as we go away from the disc, the index disc and the Camden's triangle, it is difficult to access by the conventional techniques. The caudal herniations are more common, however the cranial are more common in the upper lumbar cases and elderly patients. So anything beyond this foramen becomes challenge. So molding of this foramen is required. And how it is done? The safest entry point is superior articular process, which can be divided in 3 zones, the upper, middle and base. And according to these zones, we can access the foramen very well. So this is one of the example, the high up migrated fragment, in which I landed extraforaminally at the tip of the superior articular process. And so this is the small video. After drilling the superior articular process, making a space and get access to the epidural space, we remove these fragments. So as you can see here, these articulating instruments are of paramount importance, and these flexible grasp are again very important, and I am in the upper part of the disc. So these fragments completely removed. So you can see here, this is the nicely decompressed epidural space, and you can see that this is the upper part of the foramen, and nicely decompressed exiting root as well. This is the exiting root. So this is the post-op MRI of the same patient, and the patient walking on the same day. So the problem here is the multiple fragments. If we target the tail, then we may not be able to access these fragments. So our target should be the central or distal nucleus as the core, rather than hunting the tail. So low herniations, we all know they can be done very well with the inside out or outside in technique. However, the high migrations, for high migration, the outside in or what we call the epiduroscopic approaches are recommended. So of course, the trajectory we have to decide according to the fragment. This is another case. You can see here the L4, L5 disc, high migrated herniation. You can see the tight foramen and the more importantly a large facet, and exiting root is not seen at all. So in these cases, if we go conventionally by blind technique, we may injure the exiting root. So landing extraforaminally at the superior articular process again is the strategy here. So in these patients, the landing at the superior articular process, then we drill craniocaudally and see the tip of the superior articular process, that is the one, and then drill it further to get access to the epidural space. Once your drilling is complete, you can see the peeping epidural fat, and then the foraminal ligaments. These are the foraminal ligaments which can be cut. You see the direction of cutter, it is downward because upward is the exiting root. So in this case there were a lot of adhesions, so we have to remove these adhesions to mobilize the exiting root, otherwise you will not be able to retract it. So some of the adhesions removed, and then this exiting root is retracted laterally and the fragment is hunted. So in the literature, the operative failure for high migrations has been 15% as compared to the 2% for the low migrations. And foraminoplasty technique improves the craniocaudal mobility to improve the access to these migrated herniations. In this paper by Casey Choi, they found that the favorable outcome in 90% cases, more than 90% cases. However, in high grade up migration, having a remnant fragment or revision surgeries are higher. So it is important to plan these high migrations meticulously, and we may note sometime we may need more than one approach and should be done by experienced surgeons only. So these are some useful instruments already been discussed. These are many posterior lateral approaches, and one should know about these approaches because many times we need to have more than one approach for one fragment. Coming on to L5S1 herniation, maybe up or down, they are difficult to access through the transforaminal because of the anatomical barriers. So because of the wide interlaminar, it is easier to get these herniations by interlaminar approaches. This is another example, a 65-year-old lady who had right hip and right knee osteoarthritis and now coming with a left leg, so she was not able to walk at all. And she had underwent surgery 15 years ago by posterior approach. So again, the transforaminal approach is recommended here. So in this case, again, I am landing in the extra foraminal landing with at the base of the SAP and pedicle junction, drilling the pedicle and SAP and removing these fragments. So this is again the multiple fragments were removed in this case. I am skipping this video because we are already late, and the idea already shared. This is the patient walking on next day. So to conclude, the transforaminal endoscopy, this is a good effective choice for migrated herniations. However, the important thing is accurate planning and proper indication, which is most crucial. And foraminoplasty, or what we call the foraminotomy, widening of the foramen, is required for high migrated herniations. And one should not try the very high migrated herniation in early career of his learning curve. Thank you.